Welcome everyone tonight to our health talk on kidney disease, renal disease with Dr. Wendy McCollum, a nephrologist, a kidney doctor at Tufts Medical Center, and connected to some other people at Sportsman. So we're very happy to have her join us tonight and share her knowledge on kidney function, kidney disease, and some of the race-based issues that have come up and the genetic issues that she'll be able to discuss with us. So thank you for joining us, Dr. McCollum.
Thanks so much. I'm really thrilled to be here. I'm delving right in, the kidneys. Most of us are born with two kidneys, kind of tucked in under our ribs like this. And the primary function of our kidneys is to filter waste products, so things that get produced as we metabolize our food and go day to day. That's the job of the kidney, to filter and get rid of in our urine. So that whatever waste products are floating around in our blood kind of come in, get filtered through. Each single filtering unit is called the glomerulus. That's this thing right here, filtering unit. And we're born with about 1 million each in each kidney. We'll filter out all the extra salt we don't need, the extra water we don't need, and dump it out into urine. We pee it out. The glomerulus is the key. So us doctors and other clinicians use this term called the glomerular filtration rate. But basically, it's just trying to say how much blood is passing through this filter each minute of the day. So kidney disease is going to damage these glomerulus, these literally fine capillaries, the filtering cheesecloth. And so if you damage these glomeruli, less blood is going to pass through, less things are going to get filtered. So lower glomerular filtration rate equals lower kidney function. The primary job of the kidney is filtering like a cheesecloth, but it does so much more. It can help with red blood cell production. It helps with your bone health and keeping your bones healthy and strong, regulates your blood pressure. It regulates the acid balance in your blood. So every time we eat meat and digest meat, it produces some acid, and your kidneys help regulate and excrete that acid. Helps keep your electrolytes nice and balanced, and it is also very strongly associated and connected with heart health. So these are a lot of different organs and a lot of different systems. So when your kidneys get sick, there can be a huge number of health problems. And so kidney doctors often will start talking about all these different other organs and things once you get to stage 4 or 5. So there's 5 stages of kidney disease, of chronic kidney disease. You would fall into CKD stage 1 if you had some sort of damage to the kidney, scarring from before, or something else. But your GFR, your function, would be normal. Stage 2 is a GFR between 60 and 90, so it's mild loss of function. And these are not numbers that even probably many doctors have memorized, but I'm just illustrating them all here to explain the stages. GFR 30 to 60, moderate loss of function. Stage 4 is a little bit more severe, so your GFR is only 15 to 30. And stage 5, your GFR is less than 15. And what I want to point out, for most adults, our GFR drops by 1 point per year just from aging alone. And this aging process starts probably around your 30s and 40s. And so we usually tell most patients that, okay, an average 40-year-old, their GFR is probably around 100. They don't have any kidney problems. And that GFR is going to drop just 1 point per year just from aging alone. Your doctor is going to perform a blood test and measure something called creatinine. And it's something that they're all going to refer to as a biomarker, but it's basically just a waste product of muscle. It's not going to be harmful in and of itself to anything. It's just something floating around in your blood that's easy to measure that we can use as kind of a marker of kidney function. So again, it's a waste product of muscle. So it comes from our own muscle or meat or muscle that we're eating. So those are the main sources of creatinine. Plug this creatinine value into a math formula, and then it spits out an estimated GFR. And these waste products like creatinine are going to accumulate, right? It's going to be those traffic cars on the highway. They will accumulate when the kidneys are not working well. So low GFR, high creatinine. And it's this math formula that has really driven all the controversy in the past couple of years. The Cockcroft-Gault formula from 1973. This was developed using data from just 249 white men. Can you believe that? This is like, they even put in, oh, if you're female, they have a variable here, but there were no females in this study. Kind of crazy. All right, so the iteration, the MDRD formula from 1999, it's a little bit better. 1,600 people, a mix of Black and white men and women, but they all had chronic kidney disease. And then the next version from 2009, that had about almost 9,000 people, Black and white men and women, all ranges of kidney function. And then the current one is this 2021 version, a little over 8,000 Black men and women. So you can see that this one didn't have a race variable. This one did over here, and this one does not. And what was found from study to study was that the blood creatinine levels were always higher in these self-reported Black participants at a proportion of their measured GFR. This is complicated, so let me show you a figure and walk you through how they came up with this information. So this is one just sample data from one of the bigger trials. Okay, so let me walk you through this picture and see why they came up with that conclusion. So each dot here represents a research participant, one person who sat in the hospital or clinic for 2 days getting this process done. And so if we take this person over here, right, they sat for 2 days, they did all these measurements, and their GFR was about 100. And this is their measured GFR on this axis over here. So higher, meaning that their kidney function was better. GFR was 100, but when you look over here, they measured their blood creatinine at the same time, and it was higher than what they would have expected for that level of kidney function. So why is this waste product accumulating, even though their kidney function is working really well? If you look at someone over here, right, they did the same test, and their measured GFR was way down in tens, right? This is like stage 5 kidney disease. This person's kidneys are not working well, and their creatinine, that waste product, is a little bit higher at 4 here. And when they kind of made these lines through all the dots, the solid black line was for the Black men in the trial. They found that it was always a little bit higher than for the white men in the trial. And there's a very similar figure for all the Black women and white women of the same trials. And so I think I put down here kind of those numbers that I quoted before, right? About 12,000 of these participants, out of the 12,000, about 3,000 were self-reported Black. And that's why all these researchers said, well, we can't discount this finding. We don't really understand why the creatinine is higher, but we want to put in a variable to acknowledge that. Oh, and like I said, there are about 1% Asian Americans. So who knows, if there are another 3,000 Asian American, maybe there would be some other data points here, and the researcher would have put in an Asian American variable. Who knows? But there's just none of that data. But I think this has generated a lot of problems, and this is kind of things that we're struggling with now, is that race, both in the research studies and in the clinical setting, is all self-report. It's not a biological variable. There's no test that I can do to say, oh, this person is I don't know, 80%. Like there's just not, it's all self-report. And I think the biggest problem is no one understands the biology of why the creatinine is higher. So becomes very challenging to talk to patients and say, oh, your GFR is this number, but if you're for this white patient in the other waiting room, their GFR is a different number. It's just too controversial. So the American Kidney Foundation and the American Society of Nephrology put together this task force. So I put all the faces of these people on this I forget what they call it, some race-based estimating equation task force. And these are like the top nephrologists, top researchers of the country that they gathered together. All of these women and all of these people down here are kidney doctors. This man is someone a chemist in the lab. The last woman is a pharmacist. And what I think is so cool is this gentleman here was a transplant recipient, and he was part of this task force. And what they did is they said, well, we still want to keep all the data from those 3,000 individuals, or make sure that their data is not dismissed. So what they did is they adjusted the mathematical formula so that all of the data can get used, and it's not just deleting that variable. So this, at the moment, is the best formula that we have. Does not include the race variable, but it still acknowledges everybody's contribution of data, and it's called the CKD-EPI 2021 version. And then the last thing that this task force came up with is, well, if creatinine is such a problem, right, we don't understand why it's higher in African-American individuals, is there another one? And they did point out that cystatin C might be another biomarker. So it's produced by every cell in our body. The most accurate formula they came up with includes creatinine and cystatin C. The only drawback, of course, is financial. It's more expensive to run at the moment than creatinine, and not every hospital has the ability to measure it. But that's kind of the tour of the last couple of years and how they've been trying to address this controversy in estimating GFR.
What causes a sick kidney?
There can be so many causes of kidney disease. Some, which I'll go through in the next section, can be genetic, meaning passed down from a parent to their kids. And others are, I think in the US, most commonly it's high blood pressure and diabetes can cause kidney disease and damage, but it can be so many things. So it's hard to say until you get evaluated. What I find the most disturbing is, of the 37 million US adults, right, that have chronic kidney disease, African Americans comprise 35%. If there's 13% of the US population African American, why of the people with kidney disease is it 35% African American? This was a recent New York Times story, came out May 17th, targeting the uneven burden of kidney disease in Black Americans. And this is from Twitter, but this is a copy of the picture that was connected with the story, saying social disparities and systemic racism contribute to the disproportionate burden of kidney disease in Black Americans. Some doctors say genetic factors must also be considered. And the APOL1 variant that they mention in this New York Times story, so if you have normal, meaning that there's no variant, you have two copies, one copy from your mom, one copy from your dad, you can get infected by this parasite. And the crazy thing is if you have this variant, one variant from either parent, the protein that this gene produces will actually kill the parasite and you survive the infection. If you get two, so one variant from mom, one variant from dad, you also survive. The parasite will get killed, but you're at much higher risk of kidney disease. And so when they looked at the US African-American population, about 50% carry this variant, one copy from mom or dad of this variant APOL1, and 13% carry two copies, so at much higher risk of kidney disease. Now, right, there's more and more research studies going on. There's more treatments that are going to be developed. And I think it's a priority for the medical community to at least detect these variants if people want to know about them. It does need a genetic test, either blood or saliva. And it's much more widely available now than several years ago. So when I was probably in medical school or as a trainee, there's a lot of resistance to ever ordering a genetic test for a patient because, my gosh, it's expensive. It's going to live with this person forever. We don't know about their insurance or life insurance things. It's not going to affect what we do. But I think in the APOL1 thing, variant, it could change things and it could make you eligible for a study. And if it's something that you want to know in terms of your risk for passing it on to your kids and these things, I think it is something worth at least having a conversation about. This is data. So every person that starts dialysis in the United States is actually captured in this national database. And so on the bottom here is the years of 2000 way over here, 2016 over here. You can see this is a line for rates of reaching kidney failure. So this is the African American one, American Indian, Asian, and whites. You can see back in 2000, American Indians actually did have a higher rate. Asians maybe also, but they started closing this gap, what we call. So they started approaching where the white Americans are. But the trouble is that the African American line is slowly coming down, maybe, but it's still way, way up here. And so the goal is really to close this, right? Can't we bring this down a little bit further in the years to come? This list might be a good list of questions about how to push your doctor and really advocate about diagnosing kidney disease and paying attention to kidneys. So I bring up his picture again because many, many people in the US are told that they have high blood pressure. And it's super common just to have high blood pressure because you either get a little bit older or it's just very common. But it is okay to push a little bit to say, why did I develop high blood pressure? Because like I said before, sometimes the kidney function and the kidney disease itself is causing the high blood pressure. And unless the doctor does some blood tests or urine tests, they may not ever diagnose this. A lot of kidney doctors are very good at managing high blood pressure also. So I think most of you, I assume, are living in Boston. It's always okay to push a little bit. You're in a city where there's tons and tons of doctors working here. Okay to push to try to be seen by one. And then this second part goes to this genetic component, right? Do you have a related family member with kidney disease? If so, it's something always to make sure that your doctor is aware of, and then may lead to some conversations about genetic reasons, something that could be passed down through the generations. If you're going to try to avoid reaching kidney failure, it means taking medications when you feel well. Because remember, at these earlier stages of kidney disease, most people feel completely well, but those treatments are daily medications, and it's hard to argue to take medication when you feel well.